It's really important when we look at stroke mortality. And when you look at your mortality data from a stroke perspective and you go, especially your hemorrhage population, you know, they're like, well, we need to get our mortality down and we need to, well, there's a couple of things to do, and we'll talk more about that. But what we also have to recognize is some of that mortality is being reflective and being respectful of the decisions that the patients and or the families have made on their behalf related to what they think is acceptable. So that's also part of this this convoluted mortality about really any of these patients, whether it's heart failure, whether it's, you know, any of those patients. But we need to also recognize, and it's helpful to sort those things out. Do we have an advanced directive or a palliative conversation versus did they die because of the stroke itself, even though we tried everything maximally that we could do? Does that make sense? It's something that we don't talk about a whole lot. I can tell you right now, when I looked at our mortality data and administration was saying, we've got to get on mortality, I said, listen, I can make anybody live, okay? We can make people live on trachs and pegs, and we can institutionalize them. That's not what they want. So it's really important to sort of sort that stuff out, again, when you're looking at your stroke mortality. But we don't acknowledge that enough. I don't think we acknowledge that quite enough at all. When we look at terminology, the term stroke really dates back to sort of the Renaissance period, when they really believed that some of these bad events were related to the stroke of God's hand, a punishment of some sort. So that's where you get the term stroke. And as we get into sort of the late 18th century, early 19th century, we're starting to scientifically diagnose things and look at science. They developed the term the cerebral vascular accident. We've sort of reverted back to the term stroke because we know that cerebral vascular disease many times is not really accidental and can be prevented. So it's really not an accident. And so you will, now the coding system still uses CVA, but again, we're typically going back to the original term stroke. The official definition is really important, and it's probably something that you guys will want to know. It's a rapidly evolving, so it's not something that comes out over time. It's rapidly evolving vascular syndrome. So when we talk about clinical localization, a little bit later today, it needs to kind of correlate with a vascular territory, okay? So it's a rapidly evolving vascular syndrome of sudden onset. It's non-epileptic in origin, creates a neurologic deficit due to focal brain, spinal cord, or retinal ischemia. Okay, that's the official definition. And we'll talk about, this gets real convoluted when especially in our hemorrhage patients, people want to confuse our trauma patients with our stroke patients. And so we're going to talk a little bit more about that. I'm going to let you guys get that down. You can take a picture of the slide. That's not going to hurt my feelings either. That's helpful. And so again, this is the official definition, okay? All right. All right, I want to make sure you guys get this.
You said it has to like correlate with a vascular
Yeah, so
area.
when I'm assessing a patient, and we'll talk more about this in clinical localization, but let me give you an example. I have a patient who comes in, female patient, in her 30s, comes in, and I'm doing a NIH. She has no facial asymmetry whatsoever, no facial asymmetry, but she can't move an arm. Her arm, she can move this one, but this one arm goes like this. But she's got no facial asymmetry at all. It doesn't go together. That arm and face is so close on that motor strip that if I have plegia on that right arm, I should have corresponding facial weakness, and I don't. And so that's why the localization is really important. So when we go and assess somebody in the ER, that's when I go, okay, is this a psych issue, or is this some spinal cord issue or something like that? And so I've seen that several times where it just doesn't correlate, or they're just encephalopathic, and that doesn't correlate to a vascular territory. Does Does that make sense?
Yeah.
Yeah, and so that's really important. When we look at some of the trauma, especially when we get to hemorrhages and that kind of stuff, we need to separate that out from our stroke population. Because it's not due to any sort of hemorrhage, it's not due to any sort of ischemic area in the brain itself. It's due to trauma, and we need to separate those things out. Yeah. Okay? All right. You all know we have stroke subtypes, right? And you all, I think this is all review for you guys. Ischemic stroke obviously accounts for about 80%. Some people will say 80 to 85% of the stroke. And we have some causal mechanisms that we will also discuss a little bit later, but just as an introduction, we want to categorize the type, because the type of the cause, the type of the cause tells us what our treatment plan should be. So it's really important to identify the large vessel athero from the cardioembolic, from the small vessel occlusion, which is also called a lacunar stroke. So you may see that on reports on MRIs. Lacune is just small vessel ischemia. Okay, we'll look at that. Stroke of other etiologies are unusual causes of stroke, and this will not be the last time that you see this. You will see this again here in just a little bit. And then cryptogenic. Now, what I would say about cryptogenic, a lot of your cryptogenic strokes are identified as cryptogenic, meaning they're hidden. The cause is not obvious. And many times we classify them as cryptogenic because maybe we haven't done the full workup. That's where in terms of the navigators are going to be important, because we need to know what that full workup should be, what is missing. I had to teach this to my hospitalist group, because they would say to me, Rhonda, the CT head is negative. The CTA is negative. If we did a CT perfusion, it was negative. I said, we need the MRI. And when we get to imaging at the end of the day, you'll understand why we need the MRI. But cryptogenic stroke should really be used when you have ruled out everything else and you've done a complete workup. When we get to imaging, and we will get to imaging today, so that's always fun for nurses, because nobody teaches you about imaging. Now, you guys see more imaging than anybody, at least on the angio side, yeah. But when the stroke appears to be embolic on imaging, and we'll see examples of that, and there's no clear embolic source. In other words, the echo's clear. There's no AFib or any of that. Then you can use ESIS. Can be used to describe the event because it's embolic on the MRI, okay? So just hang on to that. When we get to imaging, we're gonna see some of that. ESIS patients require long-term cardiac monitoring with loop recorders, okay? So they do require that. Many of our insurances require a 30-day Holter, 30-day Holter first, and then you see the cardiologist, and if that's all clear, then they can implant the loop recorder. I don't think that the insurance will go straight to a loop recorder without the 30-day event monitoring.
I think it's 2.
There's some Medicares that will do that. Very good.
Isn't it 2 week now?
Around.
Isn't it 2 week now? It's not 30 day.
Yeah, so Medicare, the way that you get around it is because if they have telemonitoring in-house,
Then you get around it.
transition, and that's kind of your monitoring.
Perfect. Okay, so you can add that into your monitoring. The in-house. Yeah. Okay. Yeah, we're starting to get around that. So that's really good, because, you know, the monitoring that you do at home, you take them off for a shower. You know, it doesn't capture all the events and all the things. So it's good that they're finally getting around to that. Okay. So this is not the last time you're going to see this, and when we get to imaging, you're going to see a little bit more. The hemorrhagic stroke also accounts for 15–20% of strokes. And our causal mechanisms for hemorrhagic stroke is going to be divided into 2 things. The non-structural hemorrhages. When you think about, and don't try to memorize that. That's what people go, oh, I gotta memorize all. Let's make it make sense. A structural hemorrhage is something that's caused by the structure in the brain itself. A vessel abnormality, a aneurysm, or something like that. That's a structural hemorrhage. Does that make sense? Don't memorize that. Memorization is like the least effective form of learning. So, so your structural hemorrhages are related to those things. Your non-structural hemorrhages are your primary hypertensive hemorrhages because there's not really an aneurysm there. There's not an AVM there or anything like that that causes it. The incidence does vary by race and mechanism. For whatever reason, Asians and men's carry the highest incidence of structural hemorrhages, like aneurysms, okay? And typically that's just across the globe, that's what you find.
Have they investigated that like further and like identified like any causal?
Yeah, I don't think we know. It's just weird, it's just in these population studies that they've done, that's what they have found. And so and this is, you know, and again, revisiting some of those things because what we find is in our research and in what we want to do in terms of data, we tend to go off on these things and we don't come back to these questions. You know, is the diet, is the change, what is happening in these populations to make them, really the genetics, perhaps. People of color carry the highest incidence of non-structural hemorrhages, and those non-structural, those primary hypertensive hemorrhages. Okay. So we'll come back. We're gonna do a whole thing on hemorrhage. I think most of us understand what penumbra is, and so that infarct zone contains some non-viable tissue, and that is the core, surrounded by this zone of vulnerable tissue, and that's penumbra. And you can see what these numbers are reflecting is the blood flow, the cerebral blood flow. That's what those numbers are reflecting. So when you get down to, this is where perfusion can sometimes be helpful. As you can see on perfusion, on CT perfusion, you can see where you have this core of decreased blood flow, and then you can see all around it in a color scheme, and we'll look at that a little bit too when we look at imaging. But the reality is that we have to restore that blood flow. The core you can't do anything about. Once it's gone, it's gone. You can't do something about that surrounding penumbra there. Okay? And my box was a little too small, I just realized that. Okay? So when we have ischemic infarction, this is what it ends up looking like over time right here. It ends up basically creating a hole there in that left MCA territory, and it fills in with spinal fluid over time. And you'll see the radiology report, they may say bland infarction, they may say, as it evolves into encephalomalacia. Encephalo meaning brain tissue, malacia meaning softening. And so you will see that too on your reports, you'll see that term encephalomalacia. That's an old stroke that's filled in with CSF. That's what that is. So, so when that infarct, when that tissue dies, the brain has cells, the macrophages, that carry that dead tissue off, but it takes time to do it. That's the reason on your CT reports, you'll say they'll have subacute, and then they'll have chronic. And so they tell that by looking at this encephalomalacia and how much has been filled in by CSF. Again, when we get to imaging, we'll see some more of that, about the progression. So we'll be able to see acute, subacute, and then that chronic piece when we get to neuroimaging at the end of the day, okay? The hemorrhagic transformation is really important for stroke program to really identify correctly. But it is bleeding into the infarcted tissue. It is bleeding into, if this was subacute, it's bleeding into the tissue that has been damaged. And you'll see that with big ischemic strokes. They are at high risk for bleeding into that. And it can occur within days to weeks from the stroke onset. It's usually associated with reperfusion within that zone because the blood-brain barrier is gone. So if you let that patient with these big strokes and you let that blood pressure right up there to 220, they're gonna bleed into that. And so, again, it may or may not be associated with clinical deterioration. And so when we look at hemorrhagic transformation, I'll tell you how to grade it. But if it bleeds into this, right here, let's say this is subacute, and it bleeds into this, they're not gonna have any more deficit than they already have. Does that make sense? So if they bleed into dead tissue, their NIH probably is not gonna change. That's the reason why the symptomatic hemorrhagic transformation definition, we really need to pay attention to that, because it has actually a worsening of the NIH, okay? So if they bled in here, and then they bled down here, and then they bled up here, well, that's gonna give you a little bit different presentation of your NIH. So, but hemorrhagic transformation is something that we want to avoid in these patients because it can complicate, it certainly can complicate their course. So we'll see that again. I do want to talk about TIAs. I want to tell you a story. I had a patient, Joint Commission was actually in our building evaluating our program, and I was doing neurosurgery and acute stroke. So I was seeing all of the ICU neurosurgery patients, and I was also responding to the code strokes in the ER. So I was the first responder for neuro there. And Joint Commission was in evaluating our program, and I did not get the page. And it was an inpatient code stroke rapid response. I went up, set off the pager, and of course the Joint Commission wanted to go, like they do. They always want to go to these inpatient or code strokes that come in through the ED. So for whatever, I don't know, I still to this day do not know how I didn't get that page, but anyway, so I had the stroke coordinator call me. She goes, "Rhonda, where are you?" I said, the neurologist just called me. I didn't get the page, I don't know why, because it was a text message that should have come up on my phone. And I just talked to the neurologist, and he's already been up there to see the patient. She said, Rhonda, you need to get down here because everybody's like, "Oh, where's Rhonda? Where's Rhonda?" And I said, "Look, where are you?" She said, "I'm in CT." I said, "I will make an appearance. But I feel like I don't have anything to add since the neurologist is like right there. But I'll go." So they were in a circle, like in the hallway, right outside CT. The patient was still in CT. And the neurologist was saying, "Listen, this patient came in last night. They had, speech problem and some drift on an arm, but it was all resolved. And the nurse called this morning saying he had those same symptoms. And I went up to see him, and he was negative. Everything was fine. And I just walked right through the middle of it, just so everybody would know I was there. And listen, if you don't know what else to do in this situation, go assess your patient, and act like you're doing something. So, so I was like, well, I don't know what else I can do. I can't contribute to any of this conversation. I'm gonna go assess the patient. Well, if you know anything about CT, they're very OCD about people stepping on their pedals and moving equipment and stuff like that. But I had been given permission to be able to step on pedals to move the patient out, to move the patient, to kind of mobilize that table. And so I told Lindsay, I said, "Lindsay, I'm gonna move this patient out on the table, let me examine him." I examined him, he was like, I said, "Hold your," I said, do you hear me?" And so his face was, he looked a little droopy, a slight, just a slight flattening of that nasal labial fold. And I said, let's do your eyes. So anyway, and I was looking at it. One eye was fine, one eye stopped midway. And I said, "Hold your arms up." And I walked out there and I said, "Excuse me, what was your exam on this patient?" And of course, they're all still standing around him. And he said, "Well, it was fine." I said, "It's not fine now. I have 1.5 syndrome right now. I'm getting a stat CTA, a CTP. I'm calling his wife. I'm calling a neurointervention because now I'm worried about a brainstem problem because I have a cranial nerve deficit in one eye. Why is that? Brainstem." And so these TIA people should scare you. That's what I'm saying. They can wax and wane. This patient came in, all they did was a CT. They didn't do a CTA on him when he came in. And so when I did the CTA, he had a non-inclusive basilar thrombus. And I called his wife and I said, "I need you to come down here." And I had her on the phone. We were doing the MRI checklist because the radiologist wanted to know how much showering of an embolus, how much stroke I had in the posterior aspect of the brain. And so I had his wife down there, the radiology nurse was getting the consent to go to thrombectomy. We had that guy in thrombectomy in like 20 minutes. We moved the table up, but we ran him straight from MRI, which just showed some scattering petechial infarcts, moved him straight over to interventional, and pulled a big clot out of the vessel. So, again, these people that present with waxing and waning, they need full imaging workup. So this, I think if I had not gone there, I think this guy, if I had not gone there to re-examine this patient, and the nurse, I had to laugh at the nurse. She goes, I told him that's what he was doing, and he didn't believe me. And I said, well, that's what'll happen. I mean, you know, so sometimes the nurses have to be sort of loud about these patients and say, no. If we haven't done imaging, we need to do imaging because we can have a non-occlusive thrombus and we can have a big problem in a minute. So this guy actually works with us, and I see him in the hallway all the time. So anyway, so he's able to go back to work and fix our CTs. So, but the incidence of TIAs varies because it's underreported, and many people don't go to the hospital for that because their symptoms resolve when they really have a brewing problem. Historically, it's defined as a sudden focal neurologic disability that resolves within 24 hours, but that's not really the case right now, and here's why. It's defined now according to a tissue definition. That's going to be important for you to know. It's a transient episode. It comes and goes, can wax and wane, of focal neurologic dysfunction caused by brain, spinal cord, or retinal ischemia without acute infarction. And in order to determine that, you need MRI. You can't tell that on CT, especially when it's early. Your CT will be negative. When these people are coming in with big deficits, your head CT will be negative, okay? That doesn't mean that they haven't had an infarct. It means that that tissue has not had time to really represent on that CT that there's a problem. And that's the reason why when we have the initial head CT, the non-con head CT that they have when they come in, what I'm looking for there is a reason not to thrombolize, right? Are they eligible for thrombolytics? I'm looking for hemorrhage. I'm looking for something that would put them at risk. You can have significant disability with a negative head CT, okay? So that's important to know. And people with TIAs in our organization, they do not go, they get a full workup. And now some places, I don't know what do you guys do? Do you keep them?
Some will go home and get outpatient workup, some will go inpatient.
Mm-hmm. Okay. Yeah, probably depends on the risk factors and all that kind of stuff.
And hypothetically, we might be catching people with the TIA in the window and thrombolizing them in the time frame before their symptoms resolve sometimes. Hypothetically, do you think that happens?
Yeah,
so
it
I know
does.
it happens because I can tell you right now, I know it happens because they come in with deficit, their head CT is negative. You don't get MRIs before you thrombolize.
No,
right?
yeah.
You do the thrombolytics if they're eligible for the thrombolytics. You do that, and then later you'll get that MRI and it'll be negative. It
Right.
doesn't mean, you could have aborted a stroke. You
So
know?
I have a follow-up question. I think I read in here that like a large percentage of people with TIAs are gonna have a stroke within the next 6 months.
We're gonna look at that.
Okay.
Yeah, we're gonna look at how to grade that.
Okay.
Yep, we're gonna look, because they're really at risk. They're at high risk. And so we're gonna look at how we sort of grade that risk.
Mhm.
Yep, we're gonna look at that, but yeah, they are at high risk for that. That's the reason why we have to take it serious. Yeah. I'd rather prevent a stroke as to deal with people who've already had a stroke. Okay, now here's the shift in TIA management. So the risk for acute stroke is major after that TIA. And MRI is very, very, very sensitive to detect that within minutes. CT is not. But we can't run people down to MRI. Number one, it's expensive. We have too many contraindications. You know, you have to fill out the stupid form and all the things. So you don't have metal in your body and all that kind of stuff. You don't have time for that. When the vision study, and this is an older study, my gosh, this is 20 years old, but it's still really interesting that even patients who have TIAs and their symptoms resolved, you can still, when you see on MRI, you can still see infarcts on MRI, and 34% of the subjects that were diagnosed with TIA in the vision study group had an actual stroke on MRI, even though 19% of those have full resolution of the symptoms. So these are those events that may be the silent infarcts that you may not have, a significant deficit from, but you actually had stroke. And this is what I had to tell the hospitalist. When they were like, well, all this stuff is negative, I said, but we have to get the MRI, because if they have a stroke on their MRI, that changes what we do with them. And so it's still important. So the standard is CT and CTA. Do y'all use a lot of perfusion here? CTP?
All of our code strokes get perfusion.
Okay. So it varies, because some people use CT plus aspects. I mean, it varies. The Alexandrovs uses CTA plus aspects is what they don't use a whole lot of perfusion. The main thing is that you're treating what you're using. You're doing vascular imaging is the main thing. And then determining the mechanism for the TIA if you can, and then treat. And prophylax them prior to discharge. Do they need aspirin? Do they, need further stuff? Do they need a statin? And, all those things that are important in that transition of care. Okay? But the shift in TIA management, we don't just send them home anymore without some sort of plan for them. And this is where I'm getting into your question here in just a little bit. Okay. When you have this ABCD squared score for the TIA, this particular scoring system originally was looking at how predictive is it of our future occurrence. And so you have 1 point for age, 1 point for blood pressure, clinical features, how long did it last, and are they diabetic, right? So all of these are sort of points. And then if you get, and then we'll look here, right here. So less than 4 points is low risk. Do you need me to go back to the slide? Do you need me to go back to that? Oh, hang on a minute. I'm sorry, I'm going the wrong way. Do you need me to go back to that at all? Yeah. I didn't mean to confuse you guys. Yeah. Okay, got it? Okay. So when you look at 90-day stroke risk, like if they score more than 5 on that, it's almost a 20% stroke risk within 90 days. I mean, this is why these people really need some modification.
Our books say 30-day stroke risk, not 90-day in the table on page 9. It's the same number, should we correct that?
Let me check my slide, because I bet the slide is not, let me check the slide first before you correct your book. Yeah. Okay. Yeah, but don't let me forget it. Okay. Write that down, yeah, write that down. Write that down, don't let me forget to look at that, because I may need to correct my slide, yeah. Okay. Epidemiology is important, and this is where I'm gonna lull you to sleep a little bit, and I apologize for that, but all of the things that we're gonna talk about is sort of why we focus on the things we do for stroke, either primary prevention, and we definitely do it for secondary prevention. But the importance of epidemiology is it follows people over time to see what type of health issues occur and what findings you might find in that particular population. So they help you define risk factors. They help you define whether groups are going to be at higher risk than most for a specific disease. And they also identify opportunities for interventions, okay? And so we've used some of these epidemiological studies to be able to define that, okay? Framingham, you will have Framingham in that book, I promise you. Framingham is somewhere in that book.
Page 2.
You got the page number?
Page 2.
Page 2, oh, it's in
And
page 2,
8.
wow, okay.
And 8.
Yeah, page 2.
Okay,
Yep.
Yeah, so obviously an old state, I mean, this predates like probably everybody in this room. But this was really the first widely regarded epidemiologic study to define risk factors for heart disease as well as ischemic stroke. They start out with, now perspective means looking forward. A cohort, like we're a cohort right here. We're a cohort right here because we exist all at the same time in one little population right here. So perspective, they're looking forward, a cohort study, which is a select group of people that sort of coexist at one particular point in time, that began in Framingham, Massachusetts in the 1950s. And they continued on not only the children, but the grandchildren of these participants. And a lot of the things that we discovered in Framingham serve as the basis for what we now know about heart disease and stroke and other vascular diseases. The problem with any study is that it's generalizable to the population you study, right? And that only makes sense. They study white people. That's not generalizable to somebody in Asia. You know, and so we have to be careful when we are generalizing studies like that, that those studies are, you can generalize them to the populations that were studied. And you'll see that in a lot of research when you look at the limitations section in your research studies. They'll say, well, it's really limited to this group because this group was less than 60. We don't know anything about groups that were over 60, as an example. The ICH guidelines, right, for intracerebral hemorrhage for blood pressure control. And we'll look at that a little bit more, but just as an example, they excluded people who came in with the attached to and the Interact 2 trials. They excluded people who came in with a blood pressure greater than 220. So we don't know if it's safe or probably safe to move their pressure to 140 over 90 without creating kidney injury. We don't know that. That's in the fine print. And so, anyway, again, anytime you're looking at something like that, generalizing it to different populations can be a little bit problematic. So I just want you to know that. Key findings: hypertension, single most important factor to modify for stroke, right? So reduction and control of blood pressure significantly reduces stroke risk. That's number one. Again, your diet matters. That whole grain intake reduces metabolic risk factors for type 2 diabetes and cardiovascular disease. They found that out. When our cholesterol levels are associated with obesity, all of these are things that we take for granted that we know now, but they didn't know that then. And so, again, just kind of going back historically, a new left bundle branch block on the EKG is the hallmark of advanced hypertension. Okay, that would get some attention if you have a new left bundle. And you came with a stroke, that'd probably get some attention. Okay, but those are the key findings there. I know you have Greater Cincinnati, Northern Kentucky Stroke Study. Okay, so this looked at sort of a really rural area in the country, and they looked across racial groups, and they found that the incidence for stroke among African Americans is significantly higher than whites in that population, and it was greatest for even younger patients. Okay. Hypertension, diabetes, number one, number two, okay? Important risk factors associated with stroke. Maybe not totally causative. Association and causation are two different things. Association just sort of walks alongside. Unless you're doing randomized, controlled, double-blind trials, you're not really sure what causes what, okay? And that gets a lot of confusion, that really creates a lot of confusion with people, because when you have two things coexisting, some people who really don't understand that difference, they make an association of causation. And unless it's randomized and controlled and placeboed, all that criteria, it really is an association. It's not necessarily a cause, okay? The risk of stroke within 3 months of a TIA in this group was almost 15%. And the risk of death was 1 in 4. That's pretty significant in this particular group of patients. But it did tell us, because we hadn't really studied, we had no information up to that point about the differences of people of color and people of European ancestry. I know you've got the Northern Manhattan Acute Stroke Study in there too. Again, prospective, evaluate patients greater than 39. What this study found was intracranial athero is more common among non-whites, okay? So, so they have a lot more intracranial stenosis. I mean, there's not a whole lot. You can't stent every single vessel there. So those are patients that now we treat with maximized medical treatment, okay? If they had hypercholesterolemia and diabetes, that was very predictive of the risk of intracranial atherome. And extracranial carotids, more common in white, okay? And then you have some predictors, elevated LDL, diabetes, smoking, hypertension, all these things that we already know are risk factors there that we take for granted that we know, but we didn't know them, okay? Again, hypertension, diabetes, AFib, and coronary artery disease are significant risk factors for stroke, no shock there. And when we look at increased waist to hip ratio, abdominal obesity is more important than BMI as a risk factor. The 2024 guidelines now in primary prevention of stroke address this. They say you can't just look at BMI. You really have to look at the hip to waist ratio, and that is actually more predictive. And so addressing that, because the BMI is imperfect. I think we all know that. And so that's important to know. It's not just about BMI. So if you get a question on that, you'll know the answer. We have a section of the country that is in the stroke, I'm in the stroke belt. We like our fried catfish. We like our fried food. And then it extends down to Louisiana, and they just love their Cajun food. I've been down there, they love their alligator gumbo. And, you know, they love all of that. And so, you know, there was a question is why is there this stroke belt, okay? So among people in a survey, in over 45 years old, among people said, hey, I don't have a history of stroke or TIA, but they did admit to one or more stroke symptoms, which is kind of interesting. It was more common among African American and low income patients, okay? And the odds of reporting a stroke symptom increased if they have some of these additional risk factors, hypertension, smoking, diabetes, sort of inactivity, and even depression. This area of the country, as you probably know, is very rural. Many of the healthcare access is not there. I mean, it just isn't there. Transportation, you may have scattered and people can't get, they don't have transportation to get what they need to go. There's a lot of health disparities in the stroke belt because of the rural areas. And some of that is the lack of trust in healthcare providers, to be honest. Lack of trust in the healthcare system. And so even in some areas, even in our cities, it's a lack of trust in the healthcare providers and what we're trying to tell them. So working with communities, like the community outreach that we do, is really, really important to get that stroke message out to different populations. African Americans with hypertension receive more intensive treatment and more types of medications, but they still have difficulty achieving their adequate control. I see this mostly in the intracerebral hemorrhage population. They come in with hemorrhage. I have to put them on multiple classes of oral meds, and as a last-ditch effort, they end up on minoxidil to get their blood pressure under control. So, and we also have to pay attention to our transgender patients, because sometimes I don't know. I had one patient who was a transgender female. I could not get her blood pressure under control. Could not. And thank goodness we have care everywhere. Do y'all use Epic? What's your?
Yeah.
And we have care everywhere. Thank goodness, because I was able to get into the endocrine records and see under care everywhere that they had been in treatment. I mean, they had been in hormone treatment, and I was like, okay, I can't. Now I realize I have to do something different with my medication management here. And so we're finally able to get on top of it. But if you can't get on top of it, you just have to add the class and add the class. So that's important for us to know as providers, but it's also important for nurses to know to educate. Yes, ma'am.
I'm curious. Did they just add depression to like their surveys versus the other studies? Because I mean, it's interesting that depression is.
I know. It's interesting that depression is in here. It's the first time that I've ever seen like a mental health question in this, and I think they just added it to the survey.
Okay.
But you could also think of depression, lack of exercise because of depressed
Yeah, all of these
symptoms,
are kind of associated,
or
they're sort of,
eating issues, smoking for anxiety
And it's,
relief stuff.
and I'll just be honest, in some of these areas, there is a real stigma in mental health.
Mm-hmm.
Depression's completely untreated
Mm-hmm.
and under-recognized.
Yeah, yeah, so depression can actually be like a precursor to some of these lifestyle things that cause the
Yeah.
hypertension. I don't know, that's just a thought,
Yeah, and I think too, economics,
yeah.
you know, economic opportunity and things like that. So I think all of that sort of folds itself in on those, but this is one of the first early studies that I had seen that really added the mental health question. I like it.
Did this study, mostly focus on the stroke belt, or was it, the continental US, like just random studies? I'm just-
It was a national-based perspective, it was a
Okay.
national-based trial.
Okay, so this could be applied to African Americans and white people across the continental United States, okay.
Yeah, and yeah, it was a national trial. What would be interesting is to see, because I haven't looked at that in a long time, to see exactly where the results were, coming from, so then you know how to generalize that.
Right.
I think Alaska would be very different than, you know, Arizona,
Yeah.
or, you know.
It's dark all the time in the winter.
It's dark all the time, yeah, it is dark all the time, yeah, sure is. Yeah, but anyway, but this is one of the first days that I've seen a mental health question, in this. So, the summary is that, indigenous people, even our First Peoples, our Native Americans, and our people of color have significantly disproportionately high burden of stroke, and they suffer stroke at younger ages. Hypertension, I told you, number one, diabetes, number two, as the highest and modifiable risk factors. But there's some other ones that are very familiar to smoking, right? Tobacco cessation is important. Dyslipidemia or hypercholesterolemia, history of stroke or TIA obviously increases their risk. Coronary artery disease, and atrial fibrillation because of the cardioembolic impact. Okay, so that's the summary right there. All right, oh my goodness, more about risk factors, good gracious. Okay. I can't do anything about how old I am, just really can't. So age is a non-modifiable risk factor, and obviously as you get older, you have a substantial increase because of the cumulative effects of what I have done over my entire life. Okay, the combined risk of fatal and non-fatal stroke increases about 9% in men and women about 10% each year respectively. We don't know in terms of race whether it is genetic, environmental, or it could be a combination of all of those things. Okay, so we're not really sure, but we know if we don't address them that increases the overall stroke risk. Low birth weight also increases the stroke risk, and we don't know why that happens. My daughter, after many years of trying to have a baby, finally got pregnant and had Henry at 25 weeks, and he was in the neonatal ICU for 4 months, and he's doing well, but there's a lot of immaturity in those vessels. A lot of immaturity, you know, they're not supposed to be having to function right now. Mama's supposed to be doing all that stuff, and he had to sort of survive on his own. So I don't know if it's the immaturity in the vessels that all of a sudden have to start working as mature vessels, if that increases that risk, I don't know. But it does increase the risk later in life. And then familiar stroke and genetic factors can increase the stroke risk up to 30%. So familiar, like acquired syndromes like lupus or factor V Leiden mutations obviously increase the risk. Okay. Now there's some modifiable, and you may think on this list, you can't do anything about a PFO, right? I mean, so when I say that they're modifiable, what I mean is not necessarily that you can't do anything with them. No, you're good. That you can always modify them, But if you know that you have a PFO and you have a previous stroke, you probably need to get that closed. There's no evidence right now that you do it as a primary prevention because, 1 in 4 people might have a PFO in the general population. So the primary guideline, the guideline in terms of primary prevention doesn't say close it. But if you've had a stroke or TIA event, then you probably need to consider the risk benefit of closing that. So some of these, you can't do anything about having sickle cell disease, but can we do something about making sure that we're hydrated? Making sure, especially the 2024 guidelines on prevention, talk a lot about pediatrics and sickle cell disease. And it was there before, but they really do have a lot of attention on that. Obstructive sleep apnea, obesity is associated with that, obviously, but there are some things we can do to mitigate the risk. So if you have a genetic factor that you can mitigate the risk, it's still modifiable to some extent, even if you can't modify the original diagnosis that you have. Hypertension is obviously one of them. Get control of that blood pressure. My husband started seeing, my PCP is a PA, and I think she's great. And so my husband had been seeing our family doctor for years, and every time he would go to the doctor, they would go, "Oh, you have white coat syndrome." So he has to switch because he switched on my insurance. And Ann says, "Your blood pressure is 150 over 95. He goes, "Yeah, I have white coat syndrome." She goes, "How do you know?" And he goes, "That's what my other doctor told me that, it just got high when I got there." She goes, "How do you know?" And so she sent him, I kept trying to tell him this, but he was, "Well, my doctor's not worried about it." Anyway, so she had him get a blood pressure monitor and had him do a log. And guess what? He's on 2 blood pressure medicines right now, and he doesn't have headaches anymore. And she goes, "How do you know?" And she just kept asking until finally he was like, "Well, maybe I don't really know." She goes, "I think that was an assumption. And what if that's not true? What if you really do have high blood pressure? And your wife is the neurosurgeon, nurse practitioner, and I just let you out of here just going, you walk in her ER with a hemorrhage." She goes, "Not interested in that, Chris." And so anyway, so now he's on some blood pressure medicine now, well controlled. But again, just getting control of that. People will tell you all the time, "I have white coat syndrome." You gotta chase that down. Atrial fib carries a 4 to 5-fold risk, increased risk of stroke. Obviously from the emboli that come from that thrombosis within the left atrial appendage, the LA. That left atrial appendage hides stuff, okay? And obviously that risk of stroke increases with age, just like any other population. But big stroke risk here. And it makes me nervous from a neurosurgery standpoint when we take people off of anticoagulation for like surgeries and that kind of stuff, because they really are at risk doing that. So it makes me a little bit, sometimes they're just not candidates. All right, let's talk about the CHADS for just a moment. This is our stroke risk in terms of AFib, okay? And so this one we used to use. So it's an older validated scale from 1 to, obviously, to greater than 4 points is a very high stroke risk, okay? And they need anticoagulation. The problem with this particular measure is that when you get into the lower risk, are you gonna do ACER or anticoagulation? What are you gonna do at the low risk? How do you know? Well, that's why we have the CHADS-VASc, because it really does help us sort out those low risk patients and adds diabetes and adds some of these vascular factors to it. So the CHADS-VASc is used now because of its risk stratification in patients determined to be low risk on the original CHADS. So if you had to choose one of them, use CHADS-VASc, especially if they are low risk, okay? But it has to do with CHF, hypertension, your age gets different points depending on how old you are, diabetes, whether they had a stroke or TIA, vascular disease, and females get a point, okay? especially as we get older. And, is that in your book, Chaz Vasquez there?
Mhm.
Yeah, somebody borrowed my book and I never got it back, so now I don't have the book.
Hey,
Yeah, so,
it was recently.
I don't know, and I'm not even sure who borrowed it, and then I keep buying new books and then I keep loaning them out and I never get them back. But it's okay, it's not a big deal. This group, you guys know, in terms of treatment with atrial fib, warfarin, we don't use too much anymore, thank goodness, because it requires a lot of lab work and a lot of up and down and diet, and people come in super therapeutic and then they come in sub-therapeutic and all the things. But again, I mean, early on compared to aspirin alone, it was better than nothing, because you got almost a 40% risk reduction with that. But now we have new drugs with the 10A drugs, rivaroxaban, apixaban. I'm seeing apixaban more. I don't see rivaroxaban just a whole lot. Y'all see more apixaban here? Yeah, we do too. Dabigatran is there, but I don't see that just a whole lot. Okay, the advantage of these direct oral anticoagulants, it's a fixed dose. Thank goodness we don't have to monitor blood and they don't go up and down on their levels. It's superior to warfarin in reducing stroke risk, not shocking because you don't have the supra and sub-therapeutic values that you did or the risk that you did with warfarin. You also don't have any known interaction with the immune complexes. Fewer drug interactions and compared to although I can't tell my neurosurgeons this, compared to warfarin, lower risk of hemorrhage. Okay, but they don't believe that. They think that nobody should be on a blood thinner. They go, everybody's on a blood thinner. I said, not everybody's on a blood thinner. And if they are on a blood thinner, they need to be on a blood thinner. Anyway, one of the other characteristics of these drugs, it's a short half-life. And so when we take them off of them, there's a higher incidence of stroke and other thrombotic events, of course. Okay? We don't really monitor their therapeutic effects. There's not a whole really good methods to do that. And then, and that should be DOAC. The reversal medications for these, we need to know what they are. Dabigatran is Praxbind. I think I've probably used that maybe twice in the last 2 years. My institution just don't see a whole lot of it. Do y'all use 4-factor PCC or do you use Andexanet?
Both, but.
You have Andexanet?
Really,
You have
yeah,
Andexanet?
but it's very limited use.
Oh, really? What's the limited use?
It's more for CT surgery, but every once in a while, neurosurgery can get it in on an urgent case for on the OR.
Oh, gotcha, okay. I'm, just as an aside, I really wished AstraZeneca had pushed a little bit harder for the FDA. When I looked at, and they didn't, Andexanet was kind of taken over by AstraZeneca a couple of years ago, and then when they did their final FDA push, FDA did not approve it because of the thrombotic risk. When I looked at the thrombotic risk, so I did this comparison slide before the FDA made their ruling because I was trying to get it on formulary where we were. When I look at the thrombotic risk for 4-factor PCC, and which is what we were using to reverse warfarin, 4-factor PCC versus FFP. And I looked at even the Praxbind. When I looked at their thrombotic events, they were up there too. And I was like, I don't know why this one has such a stringent standard when the other established ones had thrombotic rates that were up there too and were approved. So anyway, I don't work for AstraZeneca. I just wish they'd fought a little harder.
I have a question.
Yeah.
For the non-warfarin blood thinners,
Yeah.
can that delay?
Like the non-warfarin, you mean the
Like
DOACs?
like the Eliquis or
Yeah.
any of those stuff?
Mhm.
Have we found that if that delays care, trying to get it to reverse where they're not bleeding out, whereas
Oh.
like with warfarin, You can hit them with vitamin K, FFP,
Listen,
something like that.
listen, I can hit them with I can hit them with Kcentra, with warfarin. I can hit them with Kcentra and vitamin K and have an INR corrected, ready to go to the OR in 20 minutes.
Right.
Yeah, exactly.
But with the PICSPAN and stuff, like
the
how
hemostatic-
fast can that get reversed if it's an emergent where they need to get
It's
in?
pretty quick. The hemostatic efficacy in the original, in the trial
Okay.
is pretty good. The hemostatic efficacy. What happens is we compare mortality.
Okay.
And when we compare mortality, just like I said in the beginning, when we use mortality, because it wasn't a mortality study,
Okay.
it was a hemostatic efficacy study. And Ann Alexandrov will tell you that if you ask her about this on Friday, she'll tell you all about it.
I was
Yeah.
just more, well, when I started in nursing, I started in trauma.
Yeah.
And we would get somebody in with trauma and we'd be like, oh
Yeah.
crap, they're on health,
Yeah.
But that was also like 8 years ago,
Exactly.
where we were like, oh God.
Well, I'm still doing that because 4-factor PCC does nothing to block this drug. I mean, all it does is dump factors in there.
Right. And then like some of these small little rural hospitals, they might not have the reversal agent.
Yeah.
And so.
And then you have the delay in getting them to the comprehensive center.
Correct.
Yes.
So.
I think the risk for expansion is real. What you want in a case like this is to get is a bundle, and we're gonna talk about that when we talk about code ICH, because it's not just one thing.
Okay.
It is a bundle of things that we have to do.
Yeah.
That seem to make the most sense, just like any other bundle.
Yeah, I was just as an aside, like, my grandmother lives in rural South Dakota.
Yeah.
We have her on warfarin, and she
Yeah.
does her finger, they have a machine now
Yeah.
where she can do the finger pricks at home.
Yep.
And she stays consistent eating her meals. And I'm like, cool, if you eat a crap ton of broccoli, just keep at it, just keep at it.
Watch. Yeah.
And because the hospital she was at when she fell and had a huge laceration, they were able to help stop that bleed.
Mhm.
And the doctor was like, oh, well, if you were on Eliquis, like, we would have had to fly you out and try to, So it was just you were talking about the rural communities.
Yeah.
And so.
And I think technology like that, like monitoring at home and things like that we didn't always have.
Right.
Makes a huge difference in a rural community when you have technology like
Yeah.
that.
So I'm not disputing, like, because obviously these are great.
Yeah.
But I'm just thinking outside of, like,
For
Boise,
her,
area,
yeah.
and thinking of, like, these little rural populations where it's like, oh, if she would have fell, they would have had a heck of a
Let
time.
me tell you, if somebody
and
comes
hit.
in on trauma, I'd much rather be on warfarin.
So coming
Because I
going
can- because I
from
can
training as
actually-
a trauma nurse,
Yeah,
my
yeah,
first
because
thought
I can
is,
actually do something.
yeah,
Yeah.
my first thought is,
Yeah, no, I'm
oh
with you.
God, no, they're on elk, but
Yeah, no, I'm with you.
but-
I'm totally with you.
yeah,
Yeah.
it was just kind of a little bit of an aside,
Yeah,
but
exactly. Yeah.
not knocking anything, because
Yeah, no,
preventing stroke is good.
Yeah.
Duh.
And so for somebody who's able to take care of themselves like that and do that, I think that's working for her. So
Right.
if it works, if it's not broke, don't fix it.
Right. Yeah.
Okay, yeah. So these are some less well-documented stroke risk factors. Again, the 2024 guidelines in primary prevention really address these, including some of the hypercoag states with malignancy and even genetic syndrome. And again, really get into genetic-specific risk factors like hormone replacement therapy, where the oral therapy increases the risk for women postmenopausal, increases that stroke risk. Topical doesn't, and so that's important to know, if you want symptom relief. Let's talk about stroke hemodynamics for just a moment. We're going to shift gears for just a moment. When we look at hemodynamics, if you're in cardiovascular, cardiopulmonary, you care about hemodynamics, you care about cardiac output, cardiac index, all that stuff. But the hemodynamics really are dependent on the complex interaction between pressure and resistance, okay? And remember that the pressure gradient is derived from the components that make up cardiac output. So cardiac output is stroke volume times the heart rate, if you want to just. But stroke volume has 3 components to it. And that's the amount of blood that your heart can handle and is pumping out, okay? We're gonna look at that in just a minute. But the pressure gradient, really has to do with the stroke volume. Do you have enough volume? And is your heart rate, efficient enough to be able to create cardiac output? Because our brain depends on that cardiac output. The brain will soak up about 25% of that cardiac output, so it matters. The resistance also is part of this hemodynamic picture. And it's derived from the size of your arterial lumen, the size of the vessel. How about the length of the artery, right? It takes a lot more pressure to get a lot further in the body. Blood viscosity, are you hydrated? Does the blood flow smoothly, right? In sickle cell, the blood doesn't flow smoothly. It gets clogged up because of those red cells and their shape. Vascular distensibility or elasticity. My grandmother called it hardening of the arteries. Well, some of these older people need a higher pressure because their arteries are not quite as elastic as they used to be. And then some metabolic components, and we can manipulate those, and I manipulate them all the time in the neuro-ICU. I manipulate CO2 all the time because I can affect resistance if I do that. So we'll look at that just a little bit of neurocrit here. So again, contributors to pressure. Preload is the amount of blood that's in your the left ventricle prior to contraction. Okay, so what does your body, what is your body able to put in? If you're hypovolemic, your preload is low, right? Because you don't have enough volume. So that's why these people come in who are hypovolemic, they have low blood pressure. Does that make sense? They don't have enough blood, they don't have enough blood in the heart. So you have to get that volume up. They don't have enough volume, as an example. So preload is that filling up. Contractility is the heart contractility. We care about that. We care about the ejection fraction on the echo. I care about that. A lot of people there are some people who will come in heart failure and not realize that they're in heart failure. They just think they're tired. And they don't realize their EF is like 30. Okay? And then the afterload is what's left. Do you have pulmonary hypertension? Those kinds of things. So those things affect pressure generation. Okay? Those are contributors to that. Now, I'm not going to spend, yes, there is I just want to show you this, okay? I don't expect you to do this, but I want to show you this. If you see a patient who's laying, who has sort of a dilated jugular, then you need to go, are you in heart failure? Especially if they have low pressure, right? So if you see a patient laying there and they're not straining, they're not doing any of that, and they have this sort of jugular you can estimate a CVP by counting the centimeters off of this to let me see if the error's in here. You can estimate that, but the bottom line is if you see that, then you have to go, are you short of breath when you walk? I mean, you need to ask more questions, especially if this person's at 45 degrees, because that jugular should not be like that at 45 degrees, okay? And the reason why I say that is there's a lot of people who don't realize that they have this issue. So again, getting an EKG, getting a transthoracic echo so you look at the ejection fraction. I just want to point this out to you because this is something that you can see and you don't need anything else for you to be able to ask another question. So you look at where you can't see it anymore, and then you add 6 centimeters, and that's what it would take to back up the base. So this person is in a little bit of failure, okay? And you don't have to do it, as nurses, we don't have to do anything with that, but know that if they're low blood pressure and you're giving them 2 liters of fluid, then we might want to say, hey, listen, they have some jugular distension, can I get an echo? I mean, we just need to know to ask questions. Okay, especially if they're at 45.
Squeeze issue versus volume issue.
Yeah, exactly. Yeah, exactly. Yeah. Again, vascular compliance, let's look at some of these individually, I think. Yep. So the arterial system is normally highly elastic. It distends. That's what creates the pulse, right? It distends and then retracts. And it's capable of stretching. Systemic atherosclerosis reduces that elasticity, especially with people who are older, our elderly population. And so because of that, they require higher pressures to produce blood flow because it's not pumping it forward, okay? So let's look at some other patency, stenosis and occlusions. You don't, this is pretty obvious too. Induced hypertension before we knew that thrombectomy worked, before the 2015 trials, where we really didn't have a good solution for occlusion, or we didn't think we did. We used to induce hypertension, okay? And again, we still use it with aneurysmal subarachnoid hemorrhages, right? We still induce hypertension in some of those patients to get past the vasospasm. Extracranial stenosis, our carotids. Our intracranial stenosis, again, with some of our patients that have basically ICAD. You've heard that, diagnosed intracranial arterial disease there, and then vasospasm. Okay, so those things are resistant to, they're high resistance to flow, and you've got to induce some of the blood pressure to get past it. Okay. Okay, metabolic factors, I use this. Hypercarbia, so vasomotor activity, the vascular muscle layer in the arterial system is very sensitive to some of these chemicals. And I can use CO2 to my advantage, and I do. Hypercarbia creates arterial dilation. Hypocarbia creates arterial constriction, okay? So if I have a patient who has generalized edema, cerebral edema, and I have a CO2, a PA CO2 on the ABG of like 45, I don't want them to have a CO2 of 45. They have a ton of edema. I want to restrict them a little bit, and I can bring that CO2 down using the ventilator, and bring it down gently, but get them closer to a 40, 38, 40, something like that, and get them closer. So we can use that, and sometimes we will do that. I will definitely use this in herniation syndromes. You don't use hyperventilation. I will if I have an ICP crisis, in order to get my definitive treatment, whether it's a hemicrania or a push of 23.4%. So all that's that neurocritical care stuff. Okay, nitric oxide, we don't obviously use that, but nitric oxide is also a vasomotor relaxer as well. Temperature is really important to help them be euvolemic, because hyperthermia creates dilation and hypothermia creates constriction in the arteries. So you use these things. It's great when it's normal and you can auto-regulate. That's what your auto-regulation is all about. The primary concern is that your vasomotor activity is energy dependent and it's ATP dependent if you go back to your physiology. So auto-regulatory failure occurs within that ischemic zone. So you don't have any auto-regulation. So you have to do it because you don't auto-regulate those zones. That's the reason why I have to manipulate the ventilator instead of the brain going, hey, I don't need this much CO2. Well, that auto-regulation ability is really decreased in many of our patients. So looking at those ABGs and realizing that, and this is very simplistic, you can get really complicated with this, but if you have somebody with cerebral edema, shift, near herniation, and they're on the ventilator and their PA CO2 is like 45, that may be something you need to say, hey, where do you want the CO2 on this patient? I mean, do you want them, as a strategy to decrease their ICP, especially when you have a way to measure that. Okay, non-vascular pressure also increases resistance of blood flow, and so your brain is easily perfused during diastole, very easily perfused. And what I would say is that when your ICP is increased, it pushes back on the diastolic blood flow that easily perfuses the brain. So when you have an ICP issue here, it pushes back on that blood flow, which further decreases the blood flow into the brain. And so as ICP rises, and of course that makes sense because you're looking at your cerebral perfusion pressure, the only way to perfuse the brain is to drive up the blood pressure, which is kind of difficult when you have a hemorrhage and you're trying to balance all of that stuff, right? I will tell you too that the ventilator, that's the reason why we restrict PEEP on the ventilator, because intrathoracic pressure also impacts ICP. A little bit of neurocrit there. But your normal ICP should be less than 15, and if we're gonna treat it, usually they say less than 20. The trauma guidelines say less than 22. Okay, but normal is usually less than 15. Okay. Increased ICP is really unusual in ischemic stroke, and the reason why, especially if people are older, because their brains have already sort of atrophied and they have more room to accommodate swelling. They have more room to accommodate hemorrhages. And so it allows room inside the skull for expansion. That's why people can have big subdurals and not be very symptomatic with it, because they already have atrophy in their brain. So the patients who are at most risk for an ICP are younger patients with less or almost no atrophy, so those are more at risk. Patients with extremely large malignant infarction, meaning whole hemisphere, hemicranies, y'all do hemicranies here? Yeah, okay. And cerebellar infarction. There's no room in the cerebellum. And if you have an EVD here and you have a cerebellar here, that may give you a false sense of security with that brainstem. That's why that neuro assessment is so important. But again, that cerebellar infarction, what sits in front of the cerebellum is the fourth ventricle. What sits in front of that is the brainstem. So if you have a cerebellar infarction, we'll look at some of that when we do neuroimaging. You can actually obstruct CSF drainage. And these people will go to surgery right here. If there's one indication that my surgeons will almost always go to surgery on, it's a cerebellar problem to decompress them. Okay? I don't want you to get too caught up on this. This is what I want you to see on the SPAR slide over here. You see that little dip below the line? The little red dip below the line where it says ICP equals diastolic blood pressure? See that?
Yes.
That's the pushback. That's the retrograde flow from that diastolic flow that easily flows in the brain during diastole. But when you have an increased ICP, it pushes that back. And so now you further injure the brain because you can't get the blood flow in there. That's all I want you to get out of that. Okay, so those are TCDs right there. Okay. In terms of blood viscosity, obviously anything that increases the friction, right, slows blood through that arterial circuit, and of course, and so you have to increase the pressure to support the blood flow. Okay. In sickle cell disease in the primary guidelines, they really use a lot of TCD because TCD can really inform the providers on when they need to transfuse a patient. And again, the main thing is, in terms of blood viscosity, is just making sure that patients are euvolemic. That's why our I's and O's are so important. It makes me nuts when I go to the unit and I don't have I's and O's, or I have, an out, but I don't have an in, or whatever. That makes me crazy because I can't figure out what sort of status that they are in based on just that. I mean, you can look at labs and things like that, but still. All right, here's the hemodynamic summary right here. Blood flow is the product of two things: pressure gradient. Is the heart an adequate pump? Or resistance? Is something making the blood flow difficult? Okay. When resistance can't be managed, increasing the pressure is really one of the strategies and probably the most important method to maintain that blood flow. Now if you have intact autoregulation, it may happen spontaneously, but it may be, you have to manipulate that. And so that's where we're gonna manipulate our fluids, we're gonna manipulate our ABGs, our CO2, that kind of thing. I always got an echo on patients because I care about their baseline function, especially with subarachnoid hemorrhage. Subarachnoid hemorrhage patients will have changes, and we'll see that when we get in the hemorrhage section, that they're at real risk for going into Takotsubo, going into heart failure, because of all the blood and the impact that has on the myocardium. Okay, so we need to, when we're increasing pressure, we need to continue to monitor that baseline cardiac function. Okay, why don't we do this? Y'all okay? You drinking from the fire hose? It's a lot, it's a lot. Do you need to stand up? You need a break for a minute? This is the last part of this section, okay?
Let's just
Good?
do it.
All right,
Last part.
okay. I'm here for 2 days, so this is all you. If you wanna know, remember those 5 things I said, like large artery athero, cardioembolic, lacunar stroke, remember all that? It all comes from here. It all comes from the TOAST criteria, trial of ORG 10117, denaparoid, and acute stroke treatment way back in the early 90s, okay? And the reason why it was important for us to have these classifications is when we were doing the research and you're looking at testing a drug, you want to know that it doesn't cause stroke. But how do you define stroke? And so the investigators said, you know what? We want to be able to differentiate the type of stroke because people who are in AFib are already at a risk for stroke, and we don't want to confound those results because we want a successful trial. So we don't want to confound those results with people who have large artery athero, if that makes sense. So TOAST criteria is this, everything we just talked about a little bit ago, okay? Large artery athero, cardioembolism, small vessel occlusion is also known as lacunar. Yep. Stroke of undetermined etiology or cryptogenic. And again, part of this is ESIS. Embolic stroke, but we don't know a source. Okay? All of that came out of this, that's what's called TOAST criteria. So it helps us when we're either looking at an intervention or looking at a medication, categorize the type of stroke that people had. Okay, I said we were gonna do this. Here we are. So when we look at, this is why MRI is important. Okay, how many of you look at MRIs? Yeah, routinely. How many, do you know what you're looking at?
I mean, like, for, not like, but for like, looking at my patients, yeah.
Yeah.
absolutely.
Do you know sequences? Do you know anything about that?
Kinda like the way I can tell something's a rock versus a tree.
Okay, all right, well, you'll know more. You'll know more. You'll know more. When we get into neuroimaging at the end of the day, you're gonna know more, okay? I like nurses to look at imaging, and I'm gonna tell you why I like nurses to look at imaging. Because the radiologist report's not always right. So, I don't know if you know that or not. I don't know if you know that sometimes they write normal and it gets signed and they never, and there was a glitch in the system. I've had this happen to me a couple of times where the radiology report was normal. The radiologist had never looked at the report, had never looked at the film. Guess what? Not normal. And it was a nurse at the bedside who was like, there's no way that's normal. Called our night ICU nurse practitioner, who came down and interpreted his own imaging, because that's how we train them, interpreted his own imaging, and this person had a large vessel occlusion in the left MCA on a normal scan that was wrote as normal. Of course, you can imagine the quality improvement process that initiated. And of course, the radiologist was horrified.
Scary.
What happened was they got distracted, right? Somebody called them and wanted them to look at a film, and they were gonna come back and look at this because it wasn't tagged stroke. Do y'all tag your images? Like if you have acute stroke in the ED, do you tag them like CT stroke? Kurt, do y'all do that? Yeah. We do too. This one wasn't tagged stroke because it came out of CD. And they don't tag CT head stroke. And so it wasn't tagged stroke, so it didn't bump every other image, right? So they didn't know that it was urgent. The radiologist had no idea. And anyway, so long story short, went to thrombectomy and did pretty reasonable. I mean, I had to tell the radiologist, They contacted the night nurse practitioner very quickly, so we didn't, we really didn't really lose anything, but still it was horrifying. But this is MRI. This is MRI, and how I know that's MRI, and this is a DWI sequence. This is a diffusion weighted sequence. This is what you look at, and we'll look more at this when we look at MRI, but this is what you're gonna look at when you're looking for acute stroke, and it is sensitive within minutes for acute stroke. This is a lacunar infarct. And I know it's a lacunar infarct because it's in the left basal ganglia, in the sort of in that in the lentiform area, just lateral to the internal capsule and lateral to the thalamus. So it comes up as bright white on a DWI. That's how you know it's infarct immediately. When we get into reperfusion therapies yesterday, this information is going to be important to know. You see the scattered emboli on both sides? That's probably a cardioembolic because it's on both sides. It's not shooting up one side of the brain. It's on both sides. The only way you can get that is you have a shower of material. This is in the small vessels. This is a watershed. And it's in between the ACA half and the MCA half. When we get into clinical localization, we'll look at that. But this is a patient who probably had carotid stenosis on the right side, had a cystoscopy, and came out of the recovery room with stroke symptoms. And it's because they had narrowing, they could not get the blood flow distal on the MCA side and distal, and so they had right in between the territories infarcts there. So that's how you know, that's why MRI is important. We'll look more about that later. Large artery athero, again, stenosis to a major branch. We have to have vascular imaging from the arch up. So I've got to have all those verts, all of that. When we look at intracranial large artery atherothrombosis, we can also look at, for intracranial like ICAD, those patients will be typically on dual antiplatelet therapy for at least a time period. Extracranial, artery to artery, so you can get obviously a plaque from the carotid, kind of going up that same vessel, creating stroke. Clinical findings in these patients will include like just diffuse disease, right? So you have sort of that intermittent claudication, extracranial carotid stenosis, we've talked about coronary artery disease, etc. With no evidence of cardioembolic mechanism. In other words, they don't have any AFib. So you have to rule out these other things as well. And you can have two things coexisting at the same time. Again, cardioembolic, presumably caused by embolus arising from the heart and traveling through it. You can also have a shunt with a PFO or an atrial septal defect as well, but you've got to identify that, okay? Again, we talked about those loop recorders and classifying this as ESIS, so you may see that in some of your patients as well. Okay, strokes are, again, that MRI provides that signature. We saw that of that embolic stroke. When we're doing our vascular imaging, you can have both, but the MRI is going to give you a signature of that. So again, ruling out categories of stroke is going to be helpful to provide a likely mechanism of stroke. Because it matters, it has to do with the treatment options that we have. So high-risk sources, obviously valves, AFib, thrombus in the law, sixth sinus syndrome, and recent MI because they're really at risk for AFib as well. Any kind of thrombus in the heart. A dilated cardiomyopathy is actually mentioned in the primary guidelines too for stroke prevention. The heart just doesn't function very well, right? And so you can actually precipitate a thrombus there as well. Infective endocarditis as well. We have septic, septic aneurysms that can certainly throw up some clots or throw up infectious material as well into the brain. And then you have this whole big list of medium sources. I'm not interested in, you're not gonna be tested on, hey, are these medium or high risk? That's not, I don't think that's gonna be the focus. The focus is gonna be on just identifying those patients at high risk for cardioembolic stroke and making sure that they have the correct treatment that they need, which usually is anticoagulation. And then that small vessel stroke. Now, small vessel strokes are sometimes hard for new clinicians to understand, because when I get through this, in terms of the localization, it can either be pure motor or pure sensory or mixed. And the reality is, until you get the MRI, you don't really know. So it really doesn't matter. But classically, they don't have evidence of that cortical dysfunction. When we get into scales and scores, we'll see a little bit more of that. Okay, but commonly it's hypertension, diabetes, smoking, hyperlipidemia, those all coexist with that. And we'll look at a picture in just a moment, but these are caused by damage to the small perforating arteries that rise up the large arteries. And you will not see these on vascular imaging, these small arteries, okay? Again, that MRI, I showed you that small little area in that left basal ganglia that we saw. It is gonna be in the deep structures of the brain, okay? We don't really understand what causes them, but it's probably an accumulation of all the risk factors that we see up there. And really, the small vessel disease accounts for 40% of dementias. Dementia is a vascular disease. And so it makes sense that if you have, small strokes or silent strokes or things like that, that you're gonna have some cognitive issues related to them. Okay, again, stroke of other determined or unusual causes, again, genetic disorders, hematologic disorders like hypercoag states or sickle cell, non-atherosclerotic vasculopathies. What am I talking about? Like moya. People they're at great risk for stroke. Those vessels are really messed up. Venous thrombosis. You can certainly have venous thrombosis in the brain that could cause stroke as well. Arterial dissections can cause stroke from trauma. So our trauma patients, we have to be diligent with them because they get jerked around a little bit during these car accidents, and so you have to be diligent with them. They get a carotid artery dissection and throw a stroke up, okay? And then unusual embolic sources. These are very unusual. But again, in order to get here, you have to exclude that cardioembolic and that large artery atherose. So the clinicians will have to do that. And then cryptogenic stroke. Incomplete workups constitute the most common reason for that classification because they haven't completed the workup. The other thing too is if you haven't completed the workup, you don't know what your secondary prevention is. So do you need an antiplatelet or do you need an anticoagulant? So if you haven't completed the workup, then you may not be preventing a stroke at all because you may be sort of witnessing the incorrect treatment for this patient. But again, this category includes patients with no clear mechanism. I've seen a couple of things on carotid webbing, of looking for carotid webbing. I don't know if on IR, when you guys do those things, that has been identified as a mechanism for stroke when it's not showing up anywhere else, okay? And again, patients with 2 or more possible mechanisms, but you don't know which one is it, you could also call that as cryptogenic, but it's not from a failure of workup, okay? And that's what we have to do, unfortunately. Most patients, thankfully, are not cryptogenic, okay? Good gracious, okay. Intracranial classification, so let's talk about that. I do want to say one thing. Subdurals and epidural hematomas are intracranial hemorrhages, but they're not intracerebral hemorrhages. They are not strokes, okay? And that's important to point out. You don't want to go down a stroke pathway for a subdural or epidural hematoma patient, okay? But again, the brain parenchyma is just that brain tissue. And so when you have hemorrhage into that, or into the ventricles, then that is an intracerebral hemorrhage. And so typically we classify those as subarachnoid or intraparenchymal. We can have them anywhere. I can have them here, I can have them here, I can have them back here. But again, about 10 to 20% of strokes, we said, okay? Some of these patients will also extend into, particularly if it's a thalamic hemorrhage, it'll extend into that ventricle, and you may get some subarachnoid hemorrhage as well. All right, here's what I'm talking about. I think we just have a few more slides here, and then we are gonna take a break, because I'm gonna let y'all have a second. A is cortical hemorrhage. A is cortical, okay? It's near the surface of the brain. And those are the, sort of the branches, okay? When I see a patient with a cortical hemorrhage, where A is, yep, take a picture of that. When I see that, that's not normal, okay? I'm gonna look for, in an elderly patient, I'm gonna look for amyloid angiopathy. In a younger patient, or a brain tumor. Patients can bleed into brain tumors, okay? And so those are not classically hypertensive hemorrhages right there. I don't have a pointer either. I wish I had a pointer. Okay, B, at least I have letters. B are the basal ganglion hemorrhages. You have a lot of those. There's a bunch of them. Basal ganglion hemorrhages are in the deep structures of the brain. They are by definition subcortical. Why? Because they're under the cortex. You see these little convolutions like this? I don't know, these, you know, all across the, yeah, yep. And so you see all that's cortex on the outer part of the brain. Once you get under that, it's all subcortical. B is where your, if you have a ischemic stroke there, that's your lacunar stroke and all these penetrating arteries. That makes sense? Okay. C is the thalamic stroke. And those originate from the thalamo-geniculate branches off the PCA. So it comes out the posterior cerebral artery. Those are the patients that you will have in interventricular extravasation, is that those the thalamus forms the wall of the third ventricle. So if you have a bleed in the thalamus, you're gonna have blood in the ventricles. Those are difficult patients. Those patients usually end up with EVDs. Brainstem, you see 10 off those pontine perforators, off those pontine perforators. Those are the perforators off the basilar artery, okay? And E is the cerebellum. Again, off the brain, all of these are off the branches. They're not off the large vessels. They're not like aneurysms, like we would think of as aneurysms. They're all off those small vessels. And again, hypertension being one of the main risk factors in diabetes because of the vasculopathy that, the results of that, okay? Y'all got a picture of that? Yeah, okay. So those are the most common IPH locations. The rule of bleed helps determine the mechanism. I can tell it when I look at the CT. And then I know, do I need to do something else? And we're gonna talk about that a little bit more tomorrow. Funny looking bleeds occur in unusual locations, and I start looking for stuff. So if I see something in a young person on the surface, I'm gonna look for a brain tumor. I'm gonna look for an AVN. That's not normal. That's not a hypertensive bleed. I don't care if they come in hypertensive. That is not a common location. Basal ganglia is, but not those surface lesions like that. Okay? All right. Mechanisms, hypertension being one of them. We have to control that blood pressure, and we'll see a little bit more of that tomorrow. Trauma, we have to separate the trauma population out unless they had a stroke first and then had a trauma. The trauma, contusions, the trauma, those things are not primarily stroke. And Kirk, that's an important thing for y'all to know in your program, is that we don't need to code those as stroke patients. And so I really had to work with our coding teams not to do that. Cerebral amyloid angiopathy, where the vessels deposit a protein in the vessel and it makes it more fragile. You typically see that in older patients. I have to think about, is this a location that could be hiding aneurysm? So when I look at that, we also have to say, are they hiding something else? Which is a reason why we get a CTA. Venous thrombosis, you gotta make sure that you know that you're ruling that out as well. And a CTA, sometimes we'll do that, especially if you get a venous phase on any of these illegal drug use, again, looking for brain tumors and then looking for infection, because you can have an abscess there as well. Okay, this is what a hypertensive bleed looks like. This probably originated in the thalamus. You see all that white stuff there? That's a CT. All that white is blood. That patient's not going to do so well. Okay, majority are subcortical, as we looked at, and the expansion risk is front loaded. So many expand significantly within the first hour. That's the reason why we have to do a bunch of stuff in that first hour, which is control blood pressure, reverse coagulopathy, and so forth. A couple of other things here: subarachnoid hemorrhage. We're gonna get more into this tomorrow, so I'm not gonna spend a whole lot of time here, okay? Because we're gonna go in depth in this tomorrow. But again, subarachnoid hemorrhage, aneurysmal being the one that we really are concerned about here. And vascular malformations are really rare. But when I have a funny looking bleed and it's cortical, I know, gotta look at that. Again, you can have some AVMs that have direct artery to venous anastomosis, and so you can get some steal phenomenon that worsens, and you can have quite large AVMs in some of these patients, and they're not always going to be amenable to surgery because of them. You have feeding arteries. The nidus is the point of that arterial-venous connection, and it's abnormal. And so that's the point of that, and we do not go willy-nilly go into surgery with these patients, because I want to identify that, the point of the connection. You don't want to get in a mess. You can literally bleed somebody out on the table if you get into that. And so that's the reason why we'll get radiology to do our angio through those vessels, and sometimes they can embolize them for us and make it a lot, and then you let things calm down. Again, most commonly, these are symptomatic by the 2nd through 4th decade of life. Okay? Oh, thank goodness.